right, we're here to talk about the impact of trauma on parents and their parenting. And of course, we know all about trauma because of the Adverse Childhood Experience study. And I'll click through this, but I'm not going to spend a lot of time going over this. I assume everybody online is pretty familiar with this. And you may also be familiar with the idea that because of the privilege of this particular population, where they had over 17,000 participants in their research, they were missing some of the things that we now consider to be traumas or chronic stress. And so here's a quick list of those things. School and community violence, disasters and accidents, invasive or prolonged medical procedures, discrimination and oppression, and of course, the thing that sort of overrides all the rest of it is poverty. So because of that level of privilege of those original study participants, they all had great insurance. Kaiser Permanente out in California at the time, they didn't necessarily report all of these sorts of things, but most people who measure trauma now include all of these categories. So we're going to take a look at a very specific population. This data comes from the FIT program, and you can see that little acronym in the bottom left-hand corner of the screen, Family Informed Trauma Treatment Center. This is out of Maryland. And if you see that little icon on the slide, the data and the information is from them and their programming with their permission. But I want to give them credit for that. And so what they did is they looked at, one of the first things they looked at was trauma exposure. And the first they pulled out just women because their program was working with moms. And they looked at the ACE study sample of women, which is that middle column there. And you can see that over 35% of the people in the original study said they didn't report any trauma or adverse experience. And only and 25% added on to that reported only one thing. And so right there you have, well over 50, you're at 60% of the entire population saying not that much. We don't relate to it that much. If you look at the next column, it says B moms. That stands for Baltimore moms, and it was their sample. So we're shifting from this privileged population to a population that's already deeply involved with some pretty intensive behavioral health programs. And as you can see, that 60% moved right to the bottom of the list where they are almost all reporting. Most people are reporting having 4 or more of the traumas. And I want to assume, but perhaps I shouldn't, that you know what the 4 or more means. Anybody have any, can you connect the dots there? There's a lot of, of course, there's just dozens, hundreds, thousands of studies that came out of the ACE study. And one of the things they recognized early on was when people had a score of 4 or more of the traumas, any of the ones that I just listed, it changes their neurodevelopment. And it's all about the brains, right? And so that's a tipping point for us, and it presents those people who have 4 or more just have significantly more difficulty across the board. I won't go into that too much, but that is sort of just a thing you should keep in your head when you're thinking about ACE scores or trauma scores in general. 4 or more before your brain was fully developed really means that your brain is going to develop in a little bit different way than the rest of us. So this data is from the National Children's Traumatic Stress Network, NCTSN, and this is what they call their core data. It was collected in 2010, so it's 15 years old now, but again, we're just counting traumas here, so it still exists. As a matter of fact, the only thing I can say is it's all worse now, because of course, you might remember what happened in 2020. We lived through a pandemic, and that added trauma on top of trauma. and lots of stress. And so scores have only gotten worse. So we're going to take a look at this core data here. And what I want you to notice on this is the top two. So at almost 50% of the 14,000 people that they surveyed for this one, almost 50% experience either loss of a caretaker or domestic violence in the home. And the very next one, impaired caregiving. So a huge amount of impairment have to do with a violation of what we know to be of the standards for your parents. So it's the people that they depend on the most are the ones who are inflicting or being a part of the trauma that they're experiencing. So what I want you to notice is that with those top three items, loss of a parent, domestic violence in the home, and impaired caregiving, those traumas all involve interpersonal or relational violations. And so it's very meaningful and it's very impactful. Not that any of the traumas are easy or don't count, but these particular traumas break the social contract as we know it among family members, so that it is particularly devastating. And if you work with youth and children in general and families, you know that a huge issue is attachment. How is their attachment? Is it healthy? Is it not healthy? Is it problematic? Does it exist at all? Those sorts of things. And this has a dramatic effect on how parents and children attach. So impaired caregiving has its highest proportion of occurrence of early childhood onset. Okay. I had to say this was a surprising slide to me back in 2010 because I worked with outpatient youth and families. And so I was seeing all school age kids. And it didn't occur to me that the kids under the age of 5 would have such dramatically higher amounts of trauma than the kids who are school aged, and even less for the kids who are adolescents, teenagers. So this was stunning. And I think everybody needs to understand that the vast majority of these types of traumas are recurring before they're seen in the schools, before they're seen out in public spaces very much. And so these, it's hard for us to identify or know that they're happening because one of our biggest populations who let us know that kids are in trouble are schools and teachers. And that even if they're just connecting with the parents and saying, hey, you probably should take your child in for some service or treatment. And so that's clearly can't happen under the age of 5. They are not seen very frequently by professionals, although we are now recognizing, especially here in the state of Ohio, pediatricians may be seeing them, and they may be able to start targeting and recognizing those sorts of things. That's part of the Ohio Minds Matter website, educating pediatricians on all of these sorts of things. So just something to think about. But over 80% of our youth experience onset of trauma prior to the age of 6. And then it follows by lots of other various forms of maltreatment and domestic violence. And you can read the slide. And by the way, I will upload the slides. They're just not available at the moment because I had a little technical difficulty, obviously. I was a few minutes late getting here. And also, you're a tiny group. If somebody has a question, by all means, unmute and just talk to me. But I'll go ahead and keep moving through. So, why focus on parents' traumatic experiences? Because I'm not here to tell you about really the impact on the kids right now. We're talking about parents. And it's critical to focus on parents and the parent-child relationship because there's very little progress that can be made without improving that relationship. So let's walk through this. When parents experience their own trauma, especially when they were children, it affects their child rearing in both positive and negative ways. Now, think about that for a second. If I had trauma, my own trauma as a child, and I grow up thinking, oof, I don't want that to happen to my kid, and I do all sorts of things to make sure that that doesn't happen, that affects my child rearing in a positive way. If I had a lot of trauma and I didn't necessarily deal with it or get all the support and help that I needed, I might try to pretend it didn't happen and I'm not aware of it. And that negatively affects my child rearing practices. Let's keep going here. When we help children recover from their own traumatic experiences, parents need to be aware of their past and present so that they can actually provide safety and support during their child's development. If parents understand the past, then they can change the future and work towards ending this cycle of trauma. But if they're in denial, if they get too activated, upset thinking about their own past, they're not going to be able to do that. And so a lot of times it's the parent's history of trauma that gets in the way of recognizing current trauma and getting kids the help that they need. This is a very helpful video. It's only a few minutes long, and if we want to watch it, if you want to see it, we could watch it at the end of the presentation. But it's a hot link in the PowerPoint, so you'll have access to it as well. And it comes from the Harvard School of the Developing Child. I think that's the name of it, but it says it immediately when you click onto it. And they really talk a lot about the fact that we have to build adult capacities if we want to improve child outcomes. That you can't just fix kids. Certainly people have tried, but it doesn't stick. It's not as effective as working with and through the parents. So the relevance of parent trauma starts with there's a very high trauma co-occurrence between children and parents. So when parents experience a lot of trauma, unfortunately, their kids are likely to experience a higher than average amount of trauma themselves. Now, the parent's own trauma has the biggest impact on this. And the parent's trauma impacts whether or not they can attune to their child, whether or not they are clear on their own child rearing practices and why they would use certain child rearing practices. They might have an impaired protective capacity. If you're busy trying to minimize the idea that trauma is out there, you might not be protecting your child against all of the trauma things, even if they're reporting them to you. So there's absolutely within the family a risk of maltreatment. And of course, then there's a risk of the child developing some sort of disorder. The parents often avoid being advocates or having advocates or seeking help, and many, many times do not want to participate in any kind of treatment. Now, the bottom line to that is they don't want us digging into their trauma. They feel like that was decades ago. I didn't like it then. I don't want to think about it now. And their strategy is avoidance. And when we start working with a child or a youth and we start asking these questions, they tend to drop out pretty quick of treatment because they don't want to have to deal with their own trauma history. Now, all of this leads to poor treatment outcomes. And it's not because the treatments we have aren't reasonable, good, or helpful. It's because they drop out so frequently. This is the best slide I've ever found on trying to explain to people how ACEs or traumas cross over the generations. So I'm going to take a minute here. We're going to start at the top where somebody has suffered, a child has suffered from some significant abuse, okay? As a child, they are likely to have the blue problems, the blue boxes there. So let's just go across the row with those. As a child who suffered from or is suffering currently from child abuse and neglect, they might have behavior problems, aggression, conduct issues, difficulties getting along with other people, acting out, temper tantrums, those sorts of things. On the emotional side of things, they probably have some depression and anxiety, may or may not be able to diagnose PTSD in that instance, but those symptoms will start to pop up even in very young children. And then finally, where do we send kids? Off to school. They have trouble in school. They have trouble focusing. They have trouble because of their behavioral problems. They might have trouble making friends, getting along with teachers, even things like that. So the child is sort of set up to struggle in this instance. As the child ages and becomes an adolescent, we'll drop down to those orange circles. Let's look at other things that begin to have an impact on the child. First of all, let's start on the right this time, substance abuse. Kids with trauma histories experiment with substance earlier than kids without. For the same reasons that adults with trauma histories use substances, they're looking for a break. They're looking for something to make them feel better, even if it's just for a few moments. And so kids tend to mimic the adults, and they will try all sorts of substances. Of course, for the most part, we're talking about alcohol and marijuana, but pretty quickly it can evolve into some other even worse and more difficult things to deal with. To the left, moving to the left, school is tough for them. They have trouble making and keeping friends. They have trouble keeping up with academic work. They have trouble with all of the things at school. And so why not drop out? And whether they completely drop out, or whether they just check out and they attend, but they don't get the benefits of education. Those sorts of things are happening for sure in adolescence. And then they haven't changed in terms of diagnosis, and depression and anxiety are going to be your most salient symptoms. But they might start to qualify for that full-blown PTSD diagnosis. And finally, unfortunately, the likelihood once lightning strikes, you would like to think it won't strike again, but unfortunately, they frequently are re-victimized, whether that's from bullies at school, other adults who are supposed to be protecting them but don't, or they're re-victimized continually still in a home environment where nobody has been able to see behind the curtain yet. And so lots of re-victimization is going on. Then they continue aging with or without any assistance, and they become adults, and we have the green boxes and all the problems that adults with trauma histories and some current trauma have. Same substance abuse issues going on. Because they dropped out of school and used substances, they're likely to be at a poverty level. If they have children, they are, I can't even remember the percentage, but 4 times, 10 times as likely to have postpartum depression and serious difficulties around raising their own child. They may be involved in a relationship that includes violence and parenting problems, just parenting problems in general, because where on this chart did they get examples of or training to be great parents? And so unfortunately, the end result to a lot of this is that they may end up abusing their children directly or indirectly by neglect and not getting services and treatment for them. So there we have it. From one generation to another, we see ACEs moving on through the family. So in that, back to that FIT program that I told you about, they flat out just asked the moms to talk to them about how did your trauma experiences affect you as a parent? Now that you're in this program with us, you feel safe enough to talk, those sorts of things. And these are just all quotes from these parents, these moms who work the FIT program with them. Yes, I have bad parenting skills. I'm sure that trauma affected me. I just don't know how exactly it affected me. It made me very nervous and protective. Yes, but I don't want to talk about it. It makes me so sad. Yes, I have no patience and I know it. And yes, I hate my life. These were common responses when they were answering that question. And I think it's important to just stare at them for a second and realize how do these women feel? And do those feelings come out in their parenting? And of course, they have to. So let's look at those parenting responses. Um, those parents tend to underestimate their own child's exposure to violence. And so again, they want to turn the other way. They don't want to see it. They minimize it. They say maybe it wasn't as bad as you thought it was, that kind of thing. The second bullet point is that parents may be unaware or unable to attend to a child's internalizing symptoms. And let me try to put that in context for you. This goes back to that comment on attunement, that parents have trouble attuning to their own kids. Now, I don't know how many of you on the line are parents yourselves, but I'm guessing you understand this. When your kid cries, yelps out, and starts crying or screaming or something, can you tell the difference between I'm frustrated and mad or I'm injured and hurt? How about the difference between I'm hurt or I'm bored? How about, that's attunement. When your child is feeling something, the parent should be able to feel it too. And that's what attachment is. And attuned attachment is that I'm aware of my child's internalized framework because I understand what he looks like, what he sounds like, what he behaves like when he's in those spaces. And so when parents have their own significant trauma, instead of tuning in more to the kid, they tend to back up and be like, I don't know what's wrong. And so that is what that bullet point is about. They're unaware of or unable to attend to their child's internal world, which makes it very difficult for them to respond appropriately. The parent's traumatic reaction might create vicarious traumatic reactions within the child. So the child melts down because something bad happened to them, and they're crying and upset, and the parent it triggers the parent's traumatic reaction from their own history, and so they're busy reacting instead of busy parenting. And unfortunately, that's a really bad and repetitive cycle sometimes. And then finally, the parent's history of trauma and all their associated symptoms, like being dysregulated, not being able to have understanding relationships or positive relationships, changes in their own consciousness when they check out, dissociate, that sort of thing, changes in their self-perception. They see themselves as, I'm not a good parent, so I can't help you. And they sort of own that, but don't do anything to augment the parenting. They have cognitive distortions and changes in personal meaning of the impact on their child and their whole family's recovery. And so these are all huge interferers. So when parents have their own trauma and haven't dealt with it, this is not an unlikely constellation of difficulties. So how do those parents feel? Unfortunately, they don't feel like good parents. They feel a lot of shame and blame. They feel like they don't have any control over their own lives. They're stressed out and they feel isolated and alone. And I take this slide as a moment to remind everybody that intervention with children, particularly young children, but all youth, should really be facilitated through the child's mother or attached parent, and not one-on-one with the child and a therapist. You can make a child feel safe in your space, but if it doesn't change their most important relationship in their life, the impact will be limited. and might not be as effective as we wish it could be. The parent-child relationship is the key to recovery for both the mother and the child in these circumstances. So, how does this show up in parenting behavior? I'm just going to give you a couple of little examples here. You have a parent who has chronic depression because of their own undealt with trauma history. This chronic depression can show up in two very distinct types of parenting behavior. They tend to lean into either hostile and intrusive kinds of parenting or disengaged and withdrawn kind of parenting. And of course, we're all looking for that in between ground, right? But they tend to take it to the edge of both things, meaning that when the child that they tend hostile and intrusive is they try to control everything, and they think that if they could control everything, their kid won't come into contact with trauma, and that's the best they can do. And so they are overbearing and demanding and rather hostile in how they present their parenting strategies, that sort of thing. Whereas the disengaged or withdrawn parents, I do a tremendous amount of home-based work in the state and teach a lot of home-based providers. So we're going into these homes, and I call them the recliner parents. These are the parents who will not get off the recliner. They're overwhelmed, they're exhausted, and they stay disengaged and withdrawn, and it's a self-protective thing that they're doing. But that means the kid is left to parent themselves and do a lot of may try initially to get their parent to pay attention to them, but it's not usually received well. As a matter of fact, one of the things, another one of those videos that you can get your hands on at that Harvard website is about serve and return interactions. Okay, so for instance, when even when I walk down the hallway, if you meet somebody's eye and smiles, the likelihood that they smile back at you is very strong. It's a very innate part of us that we serve interactions and we return interactions. And so, unfortunately, when the parents are in that hostile or intrusive kind of state, the parent serves the ball in ways that are very difficult for the child to return. For instance, if the parent gets upset because the kid broke something in the house and screams and yells at the kid that they can't believe they did that, and don't you value anything, and you're just like your father. What's the right answer for the kid to give at that time? There really isn't one. I mean, are they going to argue with the parent, or are they going to deny what's going on, or are they going to just hide? It's very difficult for a kid to return any hostile kind of serve and return interaction. Or let's flip the coin. When parents are super withdrawn, they're in the recliner and they won't really engage very well, a child will constantly serve things for them. Look at me, check this out, ask me a question, answer my question, come see me, watch me jump, those sorts of things. And the parent simply doesn't offer a return. And unfortunately for all of us in these situations, neglect is even worse than direct abuse. And so being not seen is a really heavy burden on that child and can lead to a lot of difficulties in all sorts of relationships in the future. Finally, the negative parent-child interactions that are established when they're young can persist even if they do trauma recovery work and have some really good treatments. It is hard to break those patterns of interaction. So it's something that you have to look really hard for. If you get parents who are willing to participate in your treatment, in your groups, in your services, you have to really dig under the surface to see, are we changing those initial negative parent-child interactions? Here's a little visual for you. I use this often when I'm working directly with the parents. This is a cycle of triggered responses. You can start anywhere you like. I tend to start with the child being triggered. And my most common example is so the kid gets pushed around at the bus stop, bullied at the bus stop. And so the kid is upset and crying and comes home and he has a reaction, tries to tell the parent what happened. The kid's reaction, the crying, the being upset, the being hurt, that reaction triggers the parent. Um, and we say this a lot. We say that any trauma triggers our own history of traumas. That's what this is. This is that in real life, in real time. So when the kid has some sort of big reaction and the parent hasn't dealt with their own trauma, it triggers the parent's trauma, and the parent has a reaction. They might yell back. They might say, "Leave me alone." They might say, "It's not true, whatever you're trying to tell me." And that's their big trauma reaction, not necessarily based in any kind of reality. And what it does is it re-triggers the child. And you can see that this cycle could really spin for a while because there's nobody who's able or willing to step out of the cycle. As a parent, and we want to say, well, the adult has to be the one who does that. But if they're triggered and in their trauma brain, they don't have much to give at that moment. And it's very messy. And I think that's all I want to say about that. But another problem is there are a lot of challenges in addressing parent trauma. Okay, so we can't just be like, well, you must have some of your own trauma. Let's unpack that. That's hard. It's really hard to do. And when we talk about treatment, most child trauma treatment models assume that there's a protective, positively involved parent who's going to support that kid's treatment. And not just in, we're going to be here every Thursday afternoon for our group, participating in it, doing the activities and changing behaviors, attitudes, and communication, those sorts of things. When they did these evidence-based practices, they screened people and made sure that the parent was buying into it and going to attend, and that's what our data is based on. And the problem is, if you're dealing with a highly traumatized child, the likelihood that you have a traumatized parent is very high. And they're not as helpful in implementing those evidence-based treatment protocols. And so that's one problem. Let's go on to another one. Child and adult mental health systems are typically separate. And I've always been involved in the child and youth end of things. And it's true that we see parents as collaterals, and we want them to be able to do the things that appropriately with their kids that we're talking about. And we are not necessarily attending to the parents' traumatic histories or needs. And a lot of this is related to training, and probably ought to be screening for parent trauma when we're working with kids. It would give us a better chance at helping the whole family. And then finally, the adult mental health treatment system doesn't typically address people's roles as parents. They're dealing with adult diagnoses, symptoms, issues, problems, and they aren't particularly trained in seeing them as parents. And it makes it very challenging for the parents to find appropriate services that are going to meet the needs of the whole family. That is the end of the didactic, and I hope it was helpful, and I'm going to stop sharing